Many of our patients either fail upfront chemotherapy or they fail soon after. So we have a huge unmet medical need in peripheral T-cell lymphoma. And Dr. O'Connor, could we ask you to discuss the issue of relapsed, primary refractory or relapsed disease, some of the new agents and some of the exciting work that you presented in your laboratory looking at developing novel combinations?
Sure. So in the last 5 years, we've actually witnessed a remarkable increase in drugs that may have actually T-cell specific activity. We have 4 FDA approvals in the United States, starting with pralatrexate in 2009, 2 histone deacetylase inhibitors, romidepsin and belinostat, and brentuximab, of course, only approved for patients with anaplastic large cell lymphoma. The HDAC inhibitors as a class appear to exhibit some very interesting activity in T-cell lymphoma, and one of the things we've done at Columbia in New York is create a translational program to try to see if we can't evaluate some of these drugs in partnership and look at combinations of drugs. And so as we heard from the first talk on epigenetic defects and lesions, one of the combinations that we looked at that makes a lot of biologic sense is the combination of a hypomethylating agent and romidepsin. As we know, not all subtypes, but some subtypes of T-cell lymphoma have mutations in DNMT3, TET, and IDH2, which lead to global hypermethylation of the genome, and of course hypomethylating agents would reverse that. So in preclinical studies, Enrico Marchi, who was trained here with Dr. Zinzani in Bologna, did some very elegant preclinical work to establish really remarkable synergy of hypomethylating agents and romidepsin, which we've now translated to a trial very early. Only 5 patients with T-cell lymphoma have been treated, but 4 of those 5 have achieved a remission. In a more practical approach, we just took the first 2 drugs approved in the US, including pralatrexate and romidepsin, and those 2 drugs in the laboratory demonstrated marked synergistic activity. We've translated that to the clinic, and in 9 patients with T-cell lymphoma, 7 of them have achieved a response despite having received prior prala or romidepsin. And the third example that we talked about, and it's not meant to imply that these are the only examples that are being studied in terms of novel combinations, is with alisertib. And again, that demonstrated in the laboratory marked synergistic interaction, and that's being studied in the clinic by Michelle Finale at MD Anderson, and it's very early, only 3 patients with T-cell lymphoma treated, but one of those patients achieved a complete remission. So I think moving forward, there's certainly a strong rationale and merit in thinking about how to combine these novel drugs from a biological rationale, if we can, and perhaps from even a practical rationale to try to create novel combinations that we could use for the relapsed refractory setting, or hopefully move it forward to one day challenge CHOP chemotherapy.
So I just wanted to ask the panel in closing, have we changed the paradigm for the treatment of aggressive T-cell lymphomas yet? I don't know, Owen, did you want to tackle that one?
I think the paradigm is changing. It's in the process of change. And I think some of the work done by Francesco establishing the value of transplant and first remission has really been an important advance for the field. I think having new drugs to manage relapse and refractory disease puts us in a situation where some of these new drugs, which are functioning in ways that are not cross-resistant with conventional therapy, may afford us new ways to achieve complete remission and think about consolidation with transplant. And of course, the greatest limitation with CHOP, as pointed out in Francesco's talk, is our inability to get complete remissions to allow as many of those patients to move on to transplant. So I think we got to do a much better job at trying to improve that upfront therapy so we can bridge patients to more definitive therapy. And for those patients who may not be transplant candidates, chemotherapy-free approaches where patients could potentially receive that therapy for extended periods of time may offer new ways to manage it.